Hello, my name is Angelique, and today, as well as Hassini, Tran and Stephanie, we'll be discussing the use of seclusion in the mental health care setting. Seclusion is considered to be a controversial means of treatment for those suffering from mental illness. However, in 2010, just fewer than 12,000 cases were reported for that year. This equates to approximately 33 cases a day. But why, when there are so many health professionals that consider seclusion to be an outdated practice? This presentation will discuss what seclusion is, the legislation and history surrounding seclusion, how it is implemented in Australia and its effects on nurses, patients and the evidence for and against its use. For the purpose of this research assignment, we have defined mental illness as stated by the Mental Health Act as a medical condition that is characterised by a significant disturbance of thought, mood, perception or memory. The Mental Health Act defines seclusion as the sole confinement of a person to a room or any other enclosed space which is not within the control of the person confined to leave. It is a method of managing difficult behaviour based on the therapeutic principles of containment, isolation and a decrease in sensory input. That is, it is only used when all other treatments, such as talking and medication, have failed to treat the patient's mental illness. While seclusion in the past has been used as a treatment for mental illness, according to mental health legislation, it is now considered to be a management strategy for patients with aggression and violence to aid in enabling other methods, such as medication and counselling, to be utilised. However, these practices may only be used in approved mental health care services, as stated by the 2014 Mental Health Act. Strict legislation with regards to the use of seclusion have been put in place through the use of the 2014 Mental Health Act to ensure that restrictive interventions such as seclusion are only used when necessary and are only used for the shortest duration possible. A restrictive intervention is defined as an intervention that involves the use of bodily restraint and seclusion and is regulated for all individuals under the Mental Health Act. Two significant guidelines have been put in place to ensure that seclusion is only used when appropriate and it is strictly monitored. A restrictive intervention may only be used after all reasonable and less restrictive options have been tried and considered and have been found to be unsuitable in the circumstances. And a restrictive intervention may only be used when necessary to prevent serious and imminent harm to the person or another person. Bodily restraint may also be used when necessary to administer medication and treatment.
A number of safeguards have also been put into place to protect the patient whilst undergoing a restrictive intervention such as seclusion. The safeguards state that a registered nurse or medical practitioner must observe a patient in seclusion as often as appropriate, having regard to the patient's conditions but not less frequently than every 15 minutes. An authorised psychiatrist or a delegate must examine the patient in seclusion as frequently as the authorised psychiatrist is satisfied is appropriate to the circumstances to do so, but not less frequently than every 4 hours. The Mental Health Act has been put into place as the Victorian Government is committed to reducing and eliminating the use of seclusion as a treatment option for mental illness. If seclusion must be utilised as a treatment option, the authorising physician is responsible to ensure that the patient's needs are met and the dignity is preserved through the provision of bedding, clothing, food and drink, and hygiene facilities. It is now recognised that seclusion is generally only used in emergency situations and is utilised as a last resort of the treatment options. Prior to introducing seclusion, the use of straitjacket on patients, invented by Quakers, was proposed to restrain the patient and assist them to redeem self-control. Later during the 19th century, John Connolly invented the padded seclusion room in 1839 as an alternate method when patients were too violent and were at risk of harming others surrounding them or themselves, therefore having to be controlled by manual restraint, thus forcing patients to be responsible for their carelessness. Historically, seclusion was used as an inhumane intervention on those with psychiatric disorders by locking them in a filthy and unclean room, with very little light and sometimes held in manacles, isolated from other patients and staff.
The environment of the seclusion room is deemed to be a low stimulus environment so that the patient can take a break from the high stimulation of the ward. The room itself is structurally bare with only a mattress and proper bed linen provided so that the patient is not in contact with objects that they can use as a tool to harm themselves. The structure of the room can be adjusted to maintain comfort such as lighting, temperature and air circulation. The aim of the seclusion room is for the patient to take control of their behaviour. By having nothing in the seclusion room other than a mattress to sleep on, the patient can find peace and quiet and is able to reflect on their actions. Alternative measures that clinical practitioner could adopt prior to proposing seclusion as an intervention include relational, pharmacological, and environmental intervention. Relational intervention is about discussion, explanation, and being understanding towards the patient point of view. The healthcare provider is expected to show compassion, respect, and empathy towards the patient. However, this intervention may be inappropriate in an out-of-control situation. Pharmacological intervention include the use of medication to relieve mental distress, and finally, environmental intervention include the patient being taken to a private space. This may help contain the patient anxiety level and help to alleviate or prevent any further aggressive behavior. A questionnaire that was conducted in mental health hospital over 2010 and 2011 utilized patient perspective about seclusion. A majority of the patients stated they were not offered any alternative other than being put in the seclusion room. Patients felt fearful and misunderstood when they were forced in the seclusion room. Seclusion in this sense would not be perceived as a therapeutic intervention for people experiencing mental distress. Moreover, it could be deemed as a tool to take away human freedom. However, some patients found that being in the seclusion room gave them a sense of safety and a place for them to find calmness and solitude. And being confined in a seclusion room limited their aggressive behavior that could harm themselves or others. Some patients also stated that seclusion did have the benefit of allowing them to reflect on their behavior and give them the opportunity to control their emotions.
According to the Australian and New Zealand College of Psychiatrists, seclusion has long been used as an emergency measure to manage violent behaviour or agitation in mental health settings. It is used as a method of safeguarding staff, visitors and other clients who may suffer a traumatic experience or an injury as a result. The most common disruptive behaviours that directly result in seclusion include physical aggression and verbal aggression. Other reasons include patients who damage property, who attempt self-harm, who are at risk of escaping, who are refusing their medications, and patients who are refusing to cooperate with mental health staff. There are certain mental health conditions whose sufferers have a higher risk of exhibiting violent or agitated behaviour. Patients who are suffering from these conditions may therefore be more likely to require seclusion as a treatment method in the acute care setting. Examples of such mental illnesses include poorly managed or undiagnosed psychotic illnesses such as schizophrenia, antisocial personality disorder, and borderline personality disorder. A Cochrane review published in 2012 concluded that no evidence exists to either support or refute the use of seclusion. A study of Australian mental health nurses showed that the majority of participants believed that the seclusion room helped patients calm down. However, the same study revealed that the majority of participants also believed the seclusion room made patients angry, frustrated, disempowered and frightened. Both the National Mental Health Consumer and Carer Forum and the Royal Australian and New Zealand College of Psychiatrists support the reduction and elimination of seclusion where possible in Australia, under the belief that it is an avoidable and preventable practice that causes short and long-term emotional damage to patients. However, both organisations concede that there are situations where it is appropriate and necessary to use seclusion, but only as a safety measure of last resort where all other interventions have been tried or considered and excluded. It is not a substitute for inadequate resources such as lack of trained nursing staff, and it should never be used as a punishment. In conclusion, seclusion is a widely used intervention in Australia to manage violent and agitated behaviour, often associated with psychotic illness and personality disorders. Current health legislation has strict guidelines surrounding the use of seclusion. Although there are advantages to its use, current health policy supports the reduction and elimination of seclusion in mental health care facilities in Australia.